Afternoon, it's Graham Healy from Healy's Lower Back Care and Healy's Musculoskeletal. On the screen at the moment, I have part of the anatomy, and I'm going to discuss with you today how dry needling actually can eliminate hip pain and the reasons behind hip pain. Now, I've got the medical studies through PubMed and what have you, all on my website, and there's references to that. The statement is that dry needling actually works just as good as, in fact, better than, I'm saying better than, but just as good as, they've done the medical studies and what have you, than actually getting injected by steroids into the bursa. And, you know, the bursa is a fluid-filled sac that the muscles slide over. But you've got to understand why hip pain is a prevalent complaint, especially with women over 50 years of age. So without further ado, I'm not going to take too long with this. I'll just give you a little bit of an idea so that we can put it all in one picture for you. So we just have a look at the anatomy here. This is the complete anatomy by Al Siva. It's the best anatomy dissection program you can buy, and I recommend thoroughly. And I'll put a link in the video there so that you can purchase the Al Siva anatomy, complete anatomy. You can also put it on your mobile phone. I use it as a diagnostic tool. It is without question the best in the world. Okay, so we just have a look. We just look at the, and I'll rotate this around so you can see that correctly, and we'll bring up the various muscles. Now, I haven't got all the muscles on there, but I'll just pull this away so you can see me talking. Now, this area here that I've highlighted is it's a femur, but more importantly there, where all these muscles are attaching is called the greater trochanter. And so it's called greater trochanter pain syndrome, something similar to that anyhow. And as you can see, the glute medius, which I've highlighted there, is attached to the greater trochanter, and I'll just bring that out of the way so you can see it. Also, the piriformis muscle, which causes a lot of issues, that connects from the lower sacrum area, is again attached to the greater trochanter, which is the bony prominence on top of the femur. Then, of course, we've got the obitrator internus and what have you, the quadris femoris muscle, all these muscles that tie from the ilium or the hip area through to the greater trochanter contribute to hip pain, because it depends on the condition of the person, of course, but when these are, especially when they're in spasm or they're in some sort of maybe hip malalignment, one side might be slightly shorter than the other or whatever. We don't want to hit that theory too much, but definitely dry needling can relieve all those attached muscles that will affect the hip area. Now, I will put on a couple more, the more important ones. These are important. They're underneath the hip area or the muscular part of the hip area. So now I'm going to put a couple more muscles on there so you can see. The next one is the glute, the glute medius. Before that, we'll just take that one away. That was the glute minimus. Now you've got another. The glute muscles are extremely strong and can cause, when they're in spasm, can cause a lot of issues because they're connected to the hip. So, it's not a matter of, a lot of people think that, okay, we're just going to get to the bursa. Well, unfortunately, all these muscles are connected to the greater trochanter. So you've got to treat all of them, not just the bursa. And that's why the steroidal injections only work for about a few days in most cases, is because they're not getting to the root cause of the problem. And the root cause of the problem is actually the connective muscles that are under great tension over that bony prominence called the greater trochanter. As you can see, I'll highlight it again. It sits when you feel down to the side of your hip. That's what you're feeling in the hip area. Now, we'll put those muscles back on, and I will move. I've got to remind myself to move that out of the vision or out of behind me. So, okay, now we'll actually, yep, okay. As I said, that's the glute medius, and we'll keep going until we get, Now this is your problem child right here. Now this, of course, here is the glute maximus, right? And you'll notice something here. Glute maximus, the needling of the glute maximus, very important. Why? Because it connects here to the iliotibial tract. And what is the iliotibial tract? We'll bring that up a little bit, reduce it down. The iliotibial tract, and I might isolate that for you. So we're going to hit isolate. So here's the iliotibial tract. So in other words, I sort of like to liken it. It's a bit like gladrat, a very thick gladrat. It's a tendinous tissue that basically is connected down here at the just below the femur there. You'll see I'll just highlight it. No, that won't highlight, but if you can see that, I'll bring that up close. Can you see that there? So it's just connected below the patella onto the lower part of the thigh bone there. Okay, so I'll just read this out a little bit. What's it say? The iliotibial tract, or iliotibial band, is a long, strong band of connective tissue that attaches to the iliac crest, which is here. That's the iliac crest there, if you can see that. From the iliac crest to the tibia, the tib and fib. So that's the bony prominence to the tibia. So now you can see why this is going to start to be a problem, because there's a fib, which is a finer muscle, and the tibia, which is the lower part of the thigh, right? So let's just go back and we'll put that in perspective. So this very tight band of fibrous tissue is tensioned by two major muscles. One is the glute muscles. You can see how the glutes are actually attached to the iliotibial band, right? And we'll isolate that for you. So here it is. You see the glute muscle, the strongest muscle in your body actually, is attached by fibrous connections to the iliotibial band, and it's also attached to the femur there as well, as you can see that. Okay, let's go back again. Now, while I'm going through this, it's very important to understand it's not just a one-hit fix problem where you'll go and get an injection into the bursa, which is really, it's only one small part of the problem. So, okay, now we'll have a look at the major tensioner of the iliotibial band. It's right here. That's a tensor fascia latae. Always think of a cup of coffee when you say that. Tensor fascia latae. So that particular muscle is, and I'll bring it up very, very close to the screen, and I'll see if it's out of my back. My head's not. Here we go. So if I bring that up, I'll put it down a little bit. So it's actually connected to the top of your iliac crest there, or the hip bone, basically. Your colloquial terms, the anterior superior iliac crest, if you want to get all technical about it. 1/3 of the outer lip of the iliac crest. That's called the iliac crest for those medical heads out there. And it's attached here, and it tensions. It's a tensioner, like your fan belt in your car where you've got tensioners on it. Some mechanics will understand that. This actually tensions this whole iliotibial band. And this iliotibial band here, it sits right on top of the greater trochanter, or what everyone understands as your hip bone. So see, we go here. You can see it there. I'll remove it. Where are we? We'll hide that. And then I'll hide this. And look what's sitting underneath there. You see? It's all these muscles that we're talking about, right, are all connected to the iliotibial, the greater trochanter, right? And the iliotibial band slides across the top of that hip joint, or the greater trochanter. And, you know, when you feel your hip and you feel that lump in your hip, that's what you're feeling right there. So when we put that back, I'll put them back again. This here, now I'll see if I can, this is an extremely good program, and we will have a look at a bit of this particular iliotibial band connected and tensioned by the glute muscle, and also the tensor fascia latae. All these terms are in Latin. And if you want to understand what they mean, just look up the interpretation of the Latin word. It's quite interesting. Actually, the hip joint is called the acetabulum. And I looked that up because, you know, when we're at university learning all this, it's like learning another language. And I looked that up, and in Latin, or it's the old Italian, it means a vinegar cup. So the old Italians, you know, who spoke Latin at that time, they actually described the body's anatomy with things that they recognised. Oh, that looks like a vinegar cup, and the coracoid process, which sits just here near your shoulder where your bicep tendon connects onto, that actually means crow's beak in Latin. So to understand the anatomy easy, it's really, you look at what the Latin says, and you look at the interpretation, and you find that the Italians at the time, they just called it whatever they saw. So, but, you know, we've carried that terminology right through all the medical education. So you've basically got to learn another language in many respects. Fortunately, my best mate over university was Greek, and he can understand all these because the Greek, Latin, Italian, very similar. So he would understand what they're talking about, where I'd have to look it up all the time and see what the actual meaning of that particular word for me to memorize it. And I'm a visual person, so I memorize through vision, through pictures. Now, I was just about to get to the iliotibial band, and we have it in motion here. So we will give you an idea. Now, here it is. Remember, the program is The Complete Anatomy by Al Sevilla. Please, I recommend that if you want to be serious about diagnosing people's problems, you need this program. So we just see this. This is, I'll see if I can turn this around. Yes, here we go. That's one part, that's one function of the iliotibial band. As you can see that, it's rotating to the left, going along the left leg here, and the tensor fascia latae there is pulling on this band to lift the whole muscle there. Okay, and then here's another one. These are actually the function. So you'll see, let me see. Okay, this is you can see that behind me. Yeah. So this is part of it, to actually extend the leg up, or flex the leg rather, flex the main part of the leg there. And the tensor fascia latae, you can see, of course, other muscles are operating here, like your rectus femoris and what have you. But you can see how this participates in flexing the leg upwards. That's interesting. And now we'll just bring the other one up. Flexion. Okay, medial rotation. So it's important so that you understand how, I'll turn this around so you can see it in another direction. See how that the tensor fascia latae, you know, the cup of coffee muscle, and you see how that pulls in a certain direction, and it helps rotate this, there's that external rotation by the look. And also, of course, it'll be the glute muscles will assist that to a minor degree. So this muscle and this TFL gets a lot of work by people walking, sitting, running, you name it, whatever they do. There's a slide, as you can see. I'll bring this up very closely. If you can see that, see the slide effect. I want you to watch this very carefully. See that sliding? Now, this is where the bursa comes in. So there's a slide effect, right? So this tissue, this tensor fasciae latae, is sliding over your hip joint. You know, if you're 50, for 50 years, it's been sliding over your hip joint. If you're 20, you wouldn't feel it, 20 years it's been sliding over your hip joint. If you're my age, 70 years it's been sliding over the hip joint. Okay, now we will get back to, I'm going to show you what's underneath that particular muscle, and then we'll finish the video. So it's a little lesson today. Now, we'll put on the connective tissue, right? Now, this is a little nasty one that we're putting on connective tissue going on everywhere there. But most importantly, I'll just see if we've got I'll take that, I'll hide that. And I'll hide that. We'll hide that. Did we get that on yet? Yes. This is what I'm looking for. You see that green little sac there? That's what you call the hip bursa. So the trochanteric bursa of the glute maximus muscle left. So this bursa is the one that they inject, right? So when you put those muscles back on, I'll put them back on. We'll get these out of the way. Oh, hang on. I'll reverse this back a little bit. Reverse it to here. And let's have a look at the muscles. Okay. Muscles. Right. Just ignore that. The hand there with all its, once I initiate the connective tissue, it connects itself everywhere. So as you can see, the TFL, the tensor fasciae latae, and the iliotibial band, which is that there, slides, as you saw in the other video, over that bursa, and that becomes a problem. So when you go and see people, it's always, it's inflamed bursa. Well, it might be inflamed, but you've got to think about it. Why is it inflamed? Well, it's inflamed because all these connective muscles, the glute medius, the glute maximus, the actual TFL, all these muscles have tightened right up, and they've caused almost like I suppose the best thing to think about it is a tensioner on a fan belt of a car. If that tensioner is tightened right up, you'll hear the actual belt squeak like that, or it could be loosened up now. But in this case, you imagine this is all tensioned up, and the iliotibial band, which is, just to make it bigger, that's too big, bring it back here, go down a bit further, and we'll highlight it. The iliotibial band is then scraping like this, because it's all tensioned up and it's scraping over the bursa. That's why the bursa gets inflamed. The bursa just suddenly doesn't become inflamed on its own. It's all this connective tissue contributing to a tension slide. Now, what's the solution? Okay. Now, all those muscles I've just mentioned, we can dry needle those, and the procedure I do with dry needling is as taught to me by Dr. Wayne Marmu, who's, well, without doubt, he's a global best as far as I'm concerned in the application of dry needling. He's an osteopath. He's got a master's in acupuncture, and he's got a master's in dry needling, of course. And dry needling is a Western science. It's not an Eastern science. People think it's acupuncture. It's not. Acupuncture basically focuses on meridians and nerve junctions and all that, whereas we're actually penetrating the muscle in the trigger points. Now, when you see there's a trigger point right here in the TFL, it's about the center, Once we dry needle that particular trigger point, it actually releases the whole iliotibial band, and then of course connected to the iliotibial band, I'll move that out there, of course, is the glute muscles. When I remove that, that's the glute max. I hide that. Underneath, we've got the glute minimus there, and we've got to do that as well. Underneath that, I'll hide that. We've got, the glute, what did I say there before? Glute maximus, glute minimus, and the glute minimus here. And here we go. Here we've got the piriformis muscle. There are some minor muscles down there, the quadris femoris. We don't have to really worry about that too much. But those particular muscles are the ones that we focus on to make certain that we relieve all sorts of tension across the whole side of the iliotibial band. Now, the other procedure that we do is that we actually, apart from doing the tensor fasciae latae with the dry needling, we can actually needle the tendinous tissue here, because tendinous tissue has practically no blood supply, and it gets really, let me say, a bit like an old piece of leather in those people who are, clocking up a few years. So what we do is fenestrate beyond the muscle here to where the muscle connects to the tendon. And what does fenestrate mean? It just simply means we put the acupuncture needle through this tendinous tissue to give it some capillary blood flow, and it causes healing to go on in that, especially where that muscle connects to the tendinous tissue, that join part there. And the other thing is that we work down the TFL. We do the needles down the TFL. When we get to about here, where the hand is level with the TFL, we needle back up this way into the tissue. It's actually into the tendinous tissue. Now, does this hurt? No, it doesn't. It's the feeling, it gets like a heavy feeling. Sometimes we'll twitch the muscle. It certainly isn't anywhere near what it's like to get a regular sized needle into a bursa, that's for certain. So when you see the TFL, it actually holds in also, it holds in the vastus lateralis, which is one of your quadricep muscles. So this tendinous tissue holds in the whole side of your leg, basically, and the muscles slide behind it, right? And the only thing between that muscle and the bone, as I've pointed out here, and we'll take that off again. So we will hide it, and we'll bring it down so that you can see it. The only thing there, and I'll highlight it again. Whoops, there we go. That little green, we'll get rid of the TFL. We'll hide that. And there it is. There's a little sac full of fluid here that's sitting on that bony prominence, and all the muscles in the TFL, they're all sliding over it. That is why you get an inflamed bursa. But in conclusion, just hitting that bursa with a steroid needle, well, in my experience, it lasts about a couple of days best, because it's not getting the problem. It's a bit like if I treat a wound, but the wound is caused by you rubbing up against sandpaper, and you treat the wound, you put some antiseptic on it, and then you go back to rubbing it on sandpaper. It doesn't fix it at all. So the medical tests and studies have actually been done on this to verify that dry needling does in fact have a positive effect on the bursitis, on the greater trochanter there, or the hip pain, and it works just as good as, in fact, it works, in my opinion, it works better than getting a steroid injection, because you're not relying on the drug and you're going to all the connective tissues around the particular problem. You're not just focusing on that little problem there. And every person that contacts me basically says the steroid injection didn't work for them. Okay, so that's how dry needling can relieve and sometimes stop the problem altogether, because it's taking off the main motivators that are tensioning up all around over the top of that hip joint. So I hope that helps. And, regarding treatment, I mean, as I say to most of my clients, I'm still working on trying to walk on water, but I can't walk on water yet. So, usually with one treatment, which is fairly comprehensive, especially with the hip treatment, you'll get quite a considerable amount of relief. What do I recommend? Probably, a treatment once a fortnight if it's chronic. That's up to you. I don't go and say, oh, look, there's 10 treatments and $10 later or whatever it is. I don't do any of that, what I call putting people on the drip feed. What I try to do, and anyone who knows what they're doing with dry needling, we try and fix the problem as quickly as we can. If that problem's a chronic problem, yes, of course, you may need repeat treatments. Like for example, I've got a guy who's by the name of Wayne, by the way, who had a major stroke at 42. Now his speech is impaired. You can have a look on Healey'sLowerBackPain.com on the dry needling page. He asked me to do a video, so we did a video and recorded that. Now he couldn't walk downstairs because of the whole right side was affected by the stroke. He is now walking downstairs quite comfortably because of the dry needling, and because it worked. He comes to see me once a week, but not everyone has to do that. I'd say for most people, depending on the problem, once a fortnight's cool. You could do once every 3 weeks, you could do once a month. I leave it up to you. If you're getting results and it's not to do with drugs, anti-inflammatories or evasive surgery, you're on a good thing. So that's Graham Healey over and out. I hope that helps. A lot of people claiming a lot of stuff online all the time. I'm an educator. So what I decided to do was actually show you how and why the problem exists. And I'll do a few more of these videos on various other problems, because I look out there and I just see people making all these claims and they really don't analyse anything. They're just talking. I think it's marketing rubbish, actually, to be quite frank. I'm semi-retired. I care about results with people, and I do get good results because I go into a comprehensive study on every particular subject. So when someone comes to me, I think about it very carefully, analyse it. Sometimes I'll consult with Dr. Wayne Mamu, who's the global best in dry needling, and we'll talk about it. Actually, this particular procedure came from me questioning Dr. Mamu on this. So he did up a whole study and a video and everything on it, and I'm just backing up that video. Okay, Graham Healey from Healey's Musculoskeletal or Healey's Lower Back Pain.com. Thank you very much for listening, and I hope that helps.